Hi everyone, hello. I'm a DVM based in Italy. So I, since many years, work in dentistry. I have my own practice and I love dentistry. I love piezo surgery. I love periodontology. And since a few years now, I also start academy in my practice where I hold practical and theoretical courses for surgeons and technicians, basic dentistry and monographic courses on piezo surgery and periodontology. But today we are going to um, talk about a topic that is very common. It's periodontal disease, but in a new way. So we'll try to see some review. Basic knowledge of periodontal disease is always nice to start from the beginning and review some easy and basic concept. But then we'll try to master ultrasonic and hand instrumentation technique for closed root planning. And we learn also, and that's the main topic, how to integrate MicroFoam for a true periodontal regeneration. So we know that periodontal disease is an inflammation, an infection of the tissues that surround and support the teeth. So what's the periodontum? Is the supporting tissue of the teeth is gingiva, periodontal ligament, cementum, and alveolar bone. And this is the tissue that gets inflamed. How does it happen? We know. I'll just go through very quickly. So the pathogenesis of periodontal disease starts with a pellicle, and we have then plaque formation. With plaque, the tissue gets inflamed, and we get gingivitis. That's the first step of periodontal disease. And after that, we have periodontitis. So we have I found this very nice video about periodontitis that I really like because we can really see how this happens. And that's actually what happened in the mouth of our dogs and cats. Let's go straight for what is interesting for us. So the stages of periodontal disease and how we treat them. So periodontal disease, we know, is the most common problem in small animal practice. More than 80% of dogs over 3 years have this kind of disease. And what we do every day when we put dogs and cats under anesthesia is to stage periodontal disease. So we have a decision tree. So we start looking at pocket depth, radiographic bone loss, and Caucasian exposure. And with that, we'll try to stage the periodontal disease. Why do we stage it? Because if we stage it, we know how to treat it. So I think someone has a microphone on, maybe check. So why do we stage periodontal disease? Is because for every stage there's a different treatment. So we start with the first stage. This is gingivitis. We have no bone loss, normal depth, and what we do is clean and polish. So supragingival cleaning and subgingival cleaning, most important. We have then stage 2 periodontal disease, where we have pockets from 3 to 5, 6 millimeter and up to 25% of bone loss. And here the treatment, the suggested treatment is clean the pocket, so a root planing.
Hardly who. Huh? Hi.
After that, we have stage 3. Stage 3 is consider when the pocket is more than 5, 6 millimeter, or we have forcation. So and bone loss is between 25 and 50%. What we do here is GTR, guided tissue regeneration, or as we will see, and since the advent of Rigom Vet, doing a procedure with open flap and open root planing and a flap to try to regenerate the tissue. If we have more than 50% of boneless or level 3 forcation, we consider this as stage 4 periodontal disease, and the treatment is extraction. So what we know is that more than 50% of our patients have pockets between 3 and 6 millimeters, so stage 2 periodontal disease. So during our dental procedure, what we do is we measure, we do x-rays, we chart, we do a lot of things, but at the end, do we really address those patients with stage 2 periodontal disease? I have the feeling that often, especially in general practice, we don't really address the problem. And we actually seem to wait until it become bad enough to extract. So that's what happened, I think, in most of the general practice. So we have clean and polish for stage 1, clean and polish for stage 2, and the root planing that we'll see later is a different thing than clean and polish. It's not done properly. And if we have a deeper pocket, we just go for extraction. But as we said, more than 50% of our patients have those pockets. So we have a lot of patients that have stage 2 periodontal disease, and in this stage, we can still do a lot to try to save those teeth. So what's exactly closed root planing? So that's the suggested treatment for stage 2 periodontal disease. We have closed root planing is the non-surgical removal of subgingival plaque, calculus, and granulation tissue from the root surface, followed by smoothing of the root to create a biologically acceptable environment for healing. Why we do it? We do it to reduce bacterial load and inflammation, to promote gingival reattachment and pocket depth reduction, and to prevent progression of periodontal disease. This is the cornerstone of the non-surgical therapy. So I ask myself why we often don't perform closed root planing properly. And the limitation in daily practice is that usually is bundled in standard cleaning. So it's difficult to charge separately. So in the same time, we try to do a subgingival cleaning, and then we add what we should do closed root planing. So the results are often limited because we don't do it properly and we don't use the right support. And this leads to an incomplete treatment and disease recurrence. So closed root planing is the missing middle step between cleaning and extraction. But we need to know how to use it how to do it properly. In this case, we see a pocket. It's not a big pocket, but it's 4 or 5 millimeter. And with a normal scaler, it would be very difficult to clean it. But with the right tip and with the right instrument, it can be easy and we can try to save the teeth. So here comes in our help, cell foam technology. So what's the mechanism of action? So the platform technology is cell foam, a foam scaffold designed to reconnect cells in a three-dimensional environment that facilitates complex synchronal tissue repair. This cutting-edge technology has proven to be safe and effective in long-term animal studies. It's a biological scaffold for clot stabilization and tissue repair. It overcomes the limitation of traditional closed root planing, and it enables true early intervention in pockets from 3 to 6 millimeter. We call it the non-surgical solution because we know since many years Rigam Vet is on the market and it's been adopted by veterinary dental specialists globally. It gives excellent results in advanced cases and forcation. But here we have MicroFoam. It's, as I said, a non-surgical solution. It's designed for daily general practice. It's the perfect complement to closed root planing for pockets up to 6 millimeter. So it's very important to select the right patient. Why we do closed root planing in pockets up to 6 millimeter? with no mobility and furcation, because over 6 millimeter we should do a flap to open and to allow us to clean properly. The first goal of closed root planing is to clean thoroughly the pocket. And many studies show us that more than 6 millimeter pocket are very difficult to clean without creating a flap. That's because we don't have a direct visualization, and if we leave plaque or tartar or debris, infection will persist. So we'll see scaling and root planing are not the same thing. Scaling is on the crown or subgingival scaling, and root planing is on the cementum. So what's the goal of this non-surgical periodontal therapy? So closed root planing. It reduces subgingival bacterial load. That's the first main goal. So it reduces inflammation. It eliminates periodontal inflammation. That's to promote gingival reattachment. And in that way, we decrease the probing depth of the pocket. And that's for a long-term maintenance of good oral. So, but what's the difference between scaling and root planing? It's one procedure, it's a different procedure. Their procedures are done in a similar way, but are two different procedures. Scaling is just removing of plaque and calculus, so no tooth substance is removed. Why? Because we do it on the enamel. The enamel is already very glassy, and we can remove the calculus and plaque in quite an easy way, and we can leave a hard tissue that's very smooth, and after polishing even more, and this helps to delay the accumulation of new plaque and tartar. But for root planing, we need to remove the embedded calculus and then diseased cementum. On the root, we don't have enamel, so the cementum is not glassy, it's quite porous, so we need to smooth it. So I did a short video this morning just to show the difference, and we can see between the cementum. This is an extracted teeth. This is a Gracie curette. And you can see and feel and hear that the cementum is not glassy compared to the crown, to the enamel of the crown that we see in the bottom part of this tooth. So hand or ultrasonic scaling. Closed root planing can be done with hand, so with curette, or with ultrasonic scaling. Both methods are effective. There are many studies about it. Each method has distinct advantages and disadvantages. In many books and many authors advise to do a combination of both to get best results. So scaling root planing or hand root planing has been the gold standard for decades. Ultrasonic is faster, less demanding, and has also an antibacterial effect, and we'll see it later. So hand closed root planing is a complete subgingival plaque and calculus removal. How we do it? We use a hand instrument that needs to be very sharp, and with it we try to smooth as possible the root surface. This promotes gingival reattachment, and it's been, as I said, the gold standard for decades. So we need the right equipment, so Gracie curette, dental mirror, periodontal probe, and pigtail explorer. We need very sharp instruments. One of the main problems of closed root planing is that there is not a good visualization of the area. So We can use some disclosing solution to reveal residual plaque. We can use compressed air to open a bit the pocket and see if the calculus appears chalky white. Or with the Explorer or the Curette, we can have and do a tactile mapping of the pocket to check for calculus or the brights. So here's a video, and you can see under the gingiva in the pocket, after a cleaning, sometimes you can still find some calculus. So how to use it is quite easy once you learn it, but as everything, it's important to learn exactly how to do it. So blade needs to be coronal to margin and the shank parallel to the tooth. So we rotate the face flat and we insert it into the pocket base. And then, depending from the curette, we put it in the right working angulation. So usually the shank is parallel to the root. And then we start with firm, short, controlled strokes, coronally. We do overlapping strokes, longer and lighter as the surface smooths. We know that the teeth of our dog are very different from each kind of teeth and each type of dog. So there are areas where they are very difficult to reach. So we have many different curettes that we can use. It's not always easy to reach every area. So that's where comes in help the ultrasonic tips. We have thin subgingival tips with coolant that gets directly to the tip. And it gets the surface very smooth, equal or better than the curette. It's generally better at furcation sites. We need to use lower power setting as subgingivally. And it's definitely as good as effective as hand close root planning. So the advantage of ultrasound scaling is that it's less technically demanding. So it's faster, and we know that anesthesia time is critical. So it's more ergonomic in a way that we don't use strokes, and we just need to hold the scaler in the right position. And it gets superior access in deep pockets. It has also a very important antibacterial effect. Cavitation, as with the scaler, it's proven to be antibacterial. There are many different piezoelectric system, ultrasound system, that can be used. Here, I'll show you, I found this nice video of periodontal endoscopy, and that's what we should do for closed root planning. So what we see that moves is the tip of a ultrasound scaler. And with many strokes from different angle, the goal is to get everything clean and smooth. Remove granulation tissue is also very important. Here we have a furcation. We can change the tip if needed. So that's my tip selection. The black one are the one that I use with my piezoelectric unit. It's a unit where I can set power. So I'll set it a very low power. And then I have many tips, many different tips. So we have the classic beaver tail, or a very thin and in this case is also a special tip that has an abrasive area that helps to smooth better the cementum. And here we have the standard tips. So supragingival, universal, that's the one that we use usually. And then we have also perio tips for normal scalers. So EMS scaler, the red ring scaler, we can find the right tip and use it in a proper way. So what are the risks of ultrasonic scaling? So as wrong tip is definitely a risk. So with the right selection, you can check with the manufacturer of your scaler and find the right tip. Wrong power, the setting needs to be very low, or wrong pressure, but it's very difficult to have that to create damage. So definitely it needs to be cooled down to avoid pulp damage. There are no studies showing how many seconds of closed root planning can cause pulp damage, but usually authors suggest from 5 to 10 seconds from each tooth. So as with scaling, we have pathogens that can be dangerous, so strict infection required. And as with scaler, we suggest to use before the surgery chlorhexidine lavage. So it's very important, and that's the main topic, to do it and to train. And that's how we learn how to do it in a proper way. So ultrasonic scalar unit and a range of periodontal tips are essential. We can see in this video there's a forcation tip that allows us to clean the area. That's a PM4 maxillary in a medium-sized dog with a 4 or 5 millimeter pocket. It's nice to have many tips and to choose. So how is it done? Is it really different from scaling? The grasp is the same, so it's a modified pencil grip, just to have a rested hand and tactile feedback. We just use a minimum force. We just need to touch the tooth surface, and we need to stay parallel to the tooth. Constant motion, as with every piezo surgical unit, never static contact, and interrupt every 5, 10, maximum 15 seconds for suction and inspection. So with a proper tool, and if it's not a forcation or any difficult tool, it takes few seconds. So the gold standard is the combined therapy. We use ultrasonic because it's fast, efficient, and antibacterial. And we use hand curette to remove residuals and to smooth surface. That's to create the ideal healing environment. That's what is favored by the majority of human periodontists, is most time efficient and has the better clinical result. So these are real life cases, so videos sometimes are. And here comes MicroFoam. So what is MicroFoam and how we use it? So we place MicroFoam into the pocket side 1 millimeter below the gum line and apply gentle pressure for a few seconds. Closed root planing should be performed at the intended site before MicroFoam placement to ensure the site is free of plaque, calculus, and debris. So we check for pocket depth first. After that, we do our closed root planning with ultrasonic instrument and with end instrument, and then we check again just to be sure of the size, and then that's the magic. We just insert into the pocket the MicroFoam. That's as easy as it looks. So we go through again. So step one is closed root planning. If the pocket is not clean, it won't heal. So that's a standard treatment for pockets up to 6 millimeter. Hand scaling, ultrasound scaling, it provides the best environment for healing. And then we measure. So we measure to the probing depth at multiple sites to confirm indication and to eventually trim the MicroFoam if needed. That's also document baseline values for follow-up comparison. And after that, we put MicroFoam. If we need to trim it, we can trim it with a scissor. If we have to insert it 1 millimeter below the gingival margin. So the lowest picture that you see, it was my first case, and as you can see, I put it in the pocket, but it was too big, and it just popped out, and that's what we don't want. It needs to be shorter than the pocket. So for small defect, we can trim it like this way. To a small size. MicroFoam will expand slightly, so you don't need to put stitches. You just keep it there for a few seconds, and it sticks to it will absorb the fluids that are in the pocket, and it just sticks there. So that's a video from Danielle. She's a colleague that is doing a study. She's a resident, college resident. So what are the clinical benefits of
Davide, I think
MicroFoam?
the video is not really working.
It's not working?
Yeah.
Okay. Can you see the
Now,
presentation now? Yeah, great. So
sure.
what's the clinical benefit of MicroFoam? So why should we add MicroFoam to closed root planning? To stabilize the blood clot, and it provides a 3D scaffold for cell migration and proliferation. It supports the natural tissue repair. It helps us, and that's, I think, one of the most important things, to dedicate proper time and charge fairly for a real regenerative procedure. So we can do an early intervention instead of waiting for extraction. This will boost client compliance also with home care. So AVDF in Portugal this year, Paul and Danielle presented this study about MicroFoam. So the study is called The Use of Bioabsorbable Regenerative Matrix, and the preliminary result of a study looking into the use of the new micro version of bioabsorbable regenerative matrix in periodontitis in dogs. So they got adult dogs with early stage periodontitis. So they measure the pocket depth, and they evaluate with the X-rays for staging of periodontitis. So they did a split mouth study, one side with CRP and MicroFoam, and one side with CRP, closed root planning alone, and evaluation at 90 days. What they found is that there's a significant difference. The group with closed-root planing and MicroFoam had a probing depth reduction after the treatment after 90 days of 2.17 millimeter compared the study with only closed-root planing that had just 1 millimeter average of pocket reduction. So it's more than twice the gain. So what we see in the treated sites is that teeth treated with CRP, 56% of the teeth improved. So we know that closed-root planing helped a bit, not in every case. 39% of the cases just were stable, and 5% were deteriorating already after 90 days. In the group treated with CRP, with closed-root planing and MicroFoam, we had 93% of sites improved, and 7% of the sites just stay the same. So MicroFoam treated sites show significantly greater improvement in probing depth and periodontal stage than CRP only treated sites. So combined ultrasonic and hand technique are the gold standard for closed-root planing. But MicroFoam turns repair into true regeneration. We have a 93% of improvement rate in the clinical study, and early intervention can save those teeth and satisfies the owner. So we know how the owners are. When we recommend tooth extraction, they just have always something to say. So they always say, he doesn't seem to be in any pain. How will he eat without the teeth? We know he's too old. Removing teeth is reducing his quality of life. So we know the truth. Pet owners don't want extraction. They want us to save their pet teeth. So that's what we can do now. With MicroFoam, we can start performing closed-root planing on every patient with 3-6 millimeter pocket and add MicroFoam to boost regeneration. So we need to train to do closed-root planing, ultrasound, and hand. And most important thing, we can charge appropriately. So it's not bundled this into subgingival scaling or cleaning, but it's a separate procedure that we can charge for. And because we know that we can deliver a better and more predictable outcome. So let's save those teeth, I would say. Thanks everyone for your attention.